Good morning, everyone. My name is Mehdi Hamadani from Medical College of Wisconsin. In this part of the virtual debate, I will be discussing the pros and cons of cell therapies with either an allogenic transplant or CAR T cell in the management of patients with relapsed refractory mantle cell lymphoma. So let's start with the case of a stage 4 symptomatic mantle cell lymphoma patient who receives standard induction therapies, followed by an autologous transplant consolidation in late 2016. The patient relapsed in early 2018 and started an ibrutinib-based combination therapy on a trial. After a response, the patient once again relapses, and at the time of the current relapse, the patient is 69 years old with very good performance status. Now, this patient at the time of initial diagnosis did not have high risk MIPI score, and he did not have P53 gene mutation. However, his current relapse is highlighted by at least two high risk features that would warrant early consideration of cell therapies in this management. Number one, this patient relapsed within 2 years of an autologous transplant, where recent data suggests that such early relapsing mantle cell lymphoma patients have a median overall survival of only 22 months. Secondly, this patient has now failed ibrutinib, where data from many groups, including ours, show that after ibrutinib failure, median overall survival of mantle cell lymphoma patients is only 5 months. And in the recent past, later is a scenario where typically transplant programs have considered offering allotransplant in select mantle cell lymphoma patients with a curative intent. To my knowledge, the largest data supporting the role of allotransplant in mantle cell lymphoma comes from our group at CIBMTR that shows that unlike mantle cell lymphoma patients undergoing an auto transplant that remain at a sustained risk of relapse post transplantation, allografted patients after 2 years display a clear plateau in their risk of relapse, underscoring the curative potential of this modality, especially in patients with chemosensitive disease before transplant, and perhaps in a small subset of patients who have chemorefractory disease. Now, allotransplant is a curative procedure, but if we look at utilization of this procedure in the United States based on the CIBMTR data, it is very clear that in the recent years, this procedure is used infrequently and the use of this procedure is also declining. Now, mantle cell lymphoma patients are typically older, but again, registry data from CIBMTR suggests that transplant centers in the recent years have gotten very good at transplanting older patients, and the outcomes of patients above the age of 65 is very similar to outcomes of patients who are a decade older. Donor availability is also no longer a limitation, with CIBMTR data showing that outcomes of patients undergoing half-matched related donor transplant are now nearly identical to outcomes of transplants from matched sibling donors. So if patient age and availability of donor are no longer limitations, then why use of allotransplant in mantle cell lymphoma is on decline? And in my opinion, there are at least three factors that are driving our practice. Number one, as the use of allotransplant in myeloma in mantle cell lymphoma declined, it overlapped very nicely with FDA approval of several highly active BTK inhibitors, IMiDs, and proteasome inhibitors in the management of these patients. Moreover, a lot of exciting agents targeting the BCL2 pathways, novel BTK inhibitors, and novel immune therapies are also widely available on clinical trial as management options for this disease. Secondly, unlike autotransplant, where treatment-related mortality has declined sharply in the last 2 decades, same unfortunately cannot be said for allotransplantation, where treatment-related mortality is still a concern. And perhaps most importantly, CAR T cell therapies after their approval in acute B cell leukemia and aggressive lymphomas are really knocking on the doors for patients with mantle cell lymphoma as well. Arguably, the most mature data with CAR T cell in mantle cell lymphoma comes from the ZUMA 2 trial that evaluated the role of an anti-CD19 CAR therapy called X19, which is very similar to Yescarta, that is approved in diffuse large B-cell lymphoma in patients with very highly pretreated patients of mantle cell lymphoma. This trial enrolled 74 patients, but 10% of the patients never got the CAR treatment either because of manufacturing failure or early patient death because of disease progression. The 68 patients that actually received the therapy had a median age of 65 with very good performance status. 70% of these patients had high Ki67, only 17% of the patients had P53 mutations. Importantly, all of these patients had seen a BTK inhibitor, and about two-thirds were also BTK inhibitor refractory. Now, with this profile of enrolled patients, X19 appears to be highly active with overall response rates of 93% and a complete remission rate of 67%. Toxicity signal with grade 3 CRS and neurological toxicity were at 15% and 31% respectively and were not unexpected. In terms of durability of responses, the 1 year progression-free survival was 60%, which means a third of patients did lose their response within first year of getting the CAR T-cell therapy. And 60% progression-free survival is roughly what you would expect even for patients who are getting an allogenic transplant for this indication with chemosensitive disease. Now, there are other CAR platforms out there for mantle cell lymphoma. Our group is looking at a tandem dual CD19, CD20 targeting CAR in B-cell lymphomas and a subset of mantle cell lymphoma in our trial with more heavily pre-treated disease seem to be doing fine. Now, how do CAR T-cell therapies and allotransplants stack up against each other? Clearly, both of these options are powerful immunologic anti-lymphoma therapies. Allotransplant is dependent upon chemosensitivity for success. Same is not true for CAR T-cell. Allotransplant remains associated with significant rates of treatment-related mortality, while financial toxicity is arguably higher with CAR T-cells with much higher costs. CAR T-cells are not yet available in this histology as standard of care, but this will likely change by the end of this year. So how do I approach a patient with relapsed refractory mantle cell lymphoma for cell therapies? So when a patient relapses, I look for high-risk features. I see if patient got a transplant, an autologous transplant, did they relapse early after transplant? Do they have high-risk clinical features like high MeP score or high Ki67 or blastoid morphology? Are they BTK refractory or do they have high-risk genomic disease by P53 mutation or complex karyotype? If the answer to all of these questions is negative, then these patients arguably can be well managed without cell therapies, at least in their first relapse. But in patients who have one or more of these high-risk features, I think we should think about cell therapies early on, either with CAR T cells or allotransplant. CAR T cells will soon get commercial approval, and once that happens, I think it will become the go-to modality for patients with high-risk disease, especially those with poor performance score and comorbidities. Allotransplant, I think, will still continue to play a role, especially in centers who don't have CAR T-cell available or countries where this is not available. Also, I think patients with profound cytopenias and development of therapy-related myeloid disorders in the marrow are better served, arguably, with CAR T cells. P53 mutation remains an open question. Allo can cure it. We need to look at data from CAR T cell in these patients. And importantly, these therapies are not mutually exclusive. You can get CAR T cells after an allotransplant failure and vice versa. So what happened to our patient with high-risk disease? The patient, after considering his options, decided to move forward with our CD19-20 CAR T-cell trial, and so far is doing very well. I thank you all for your attention, and we'll be happy to discuss it further in the Q&A session.